recording us throughout. Okay, and another couple of announcements I would like to make is I would just like to thank my co-committee members, Dr. Lucia Fuentes and Dr. Allison Sheffield and Remy Dar, for all of the planning that went into all three of these town halls. And it's been a challenging but very, very exciting process to put this together. We'd like to thank the CUNY Office of Research and the support of Associate Vice Chancellor Schneider for encouraging us to host this forum. And most of all, we would love to thank our speakers, who I am about to introduce shortly. And we thank you to the audience for taking out your afternoon, and for some of you, the morning, to spend time with us as we discuss these very important issues. So the way this, after this final panel will go is we have 4 speakers. Each speaker will speak in sequence. We will have the question and answer period after all 4 speakers have spoken. And I will introduce each one as they are about to start their talk. I should make sure, Dr. Reddy, are you, have you made it back yet? Yes, you are. Okay, all right. Just wanted to make sure that you're here before I introduced you. Okay, so we'll start with Dr. Reddy. Dr. Sudha Reddy is the Chief Medical Officer for Clayton County Fire and Emergency Medical Services in Clayton County, Georgia. Dr. Reddy attended Morehouse School of Medicine and is an emergency physician and has practiced emergency medicine in the Atlanta area for 20 years. Her current position has allowed her the privilege and the honor to serve the citizens of Clayton County by being the first full-time medical director for fire-based EMS systems in Georgia. And today she is going to be speaking about COVID-19 in one particular location, and that is how it has affected Clayton County, Georgia. Welcome, Dr. Reddy.
Thank you. Thank you for that introduction. I am going to tie in a bit of a story of how we've managed this in our county and the opportunities. As you know, my background is in emergency medicine, went into emergency medicine actually from the corridors of public health and a history of research as well. I made a decision many years ago if I wanted to get which direction I wanted to go to professionally. And so I specifically started med school with the idea of the goal of being in an international setting, to work in all over the world in the highest risk communities. And that was originally my professional dream. Then life happened. And so the 20 years of clinical experience, my background in anthropology and in public health, I will tell you the story of how I ended up in Clayton County and how that has everything to do with addressing and looking at inequities in some of the highest risk, one of the highest risk communities here in Georgia, and definitely in the metro Atlanta area. I'm going to talk to you a little bit about the county itself first, and then I will, I'm going to share my screen, and then I'm going to talk to you about that a little bit. Can everyone see that? Okay, fantastic. So this is Clayton County. We are, if you look at the top left-hand corner, that is where Hartsfield Airport sits. So we're very, very close to, we are part of Metro Atlanta. We abut DeKalb and Fulton County. We are the 3rd most populated county in Georgia. And we are the most densely packed. It's a tiny county if you look at it. When you compare it to our neighbors, we're probably about 1/5 of the size of Fulton, and yet we have almost 300,000 individuals that live in this county. With that being said, and with our proximity to a metro Atlanta area, we have a very, very high social vulnerability index quotient. We are actually at 0.91, which it's a scale from 0 to 1. That's a very, very high quotient, especially within the United States. And within that, there's obviously a couple of things that go into that. That includes socioeconomic, household metrics, race, ethnicity, and language metrics, as well as housing and transportation. Two of our highest indexes within that are race, ethnicity, as well as transportation. The county itself is approximately 70% Black or African American, 13% Latin or Hispanic, and approximately 10% white, with a bit of Asian and biracials mixed in as well. It has with these vulnerability indexes, there's also a history of extremely difficult health access within this community. The main hospital that serviced this county almost shut down 5 years ago, and that would have provided us with no hospital. The amount of availability of healthcare resources, whether it's primary, urgent care, secondary to the economic index, that's also not accessible. And then you combine it with transportation and insurance, or lack of insurance, which rests at about 20–30% given a year, whichever year you pick. There's a very, very, being so close to some of the wealthiest counties in the state, there's an extreme disparity, extreme changes in health access, and a natural health literacy, whether it's language or just direct access or cultural health literacy that's been passed down. And that's relevant to how vaccinations and just testing and how this pandemic has rolled out through this county. With that in mind, what I'm going to do is start my storytelling part of the presentation. So you have a county which has teetered on going from very low access to healthcare to no access to healthcare 5 years ago. And as fate would have it, I had the opportunity to come and meet, and had the opportunity to meet the chief of our Clayton County Fire and EMS, that is Landry Markison. And he is both our chief resilience officer and the director of fire and EMS in EMA in our county. And 1 and 2 went together. My background, my goals, my professional expertise, and his innovation and vision for what was needed. He sat on the prior board of the hospital, and so his thoughts were, how do we bring healthcare? How do we bridge these gaps when you have all of these metrics that are in our way? And his resources were a fantastic fire department and EMS. And so 5 years ago, we started very lightly a collaboration that has borne fruit and served us extremely well when this pandemic hit, in a community that is also already so very resource poor. And so what we did prior to COVID was that we met our needs of our community. We had fire, EMS, and community treatment units. Now, the community treatment units are staffed by a nurse practitioner and a paramedic. So we were already moving into a pre-hospital treatment in place, meet people where they are, with the idea of providing bedside labs, prescriptions, kind of bridging some of that gap, bridging that primary gap that we knew existed, allowing for education, allowing for all the things that matter in terms of health literacy in their homes, because through the 911 system and through being EMS, we have that privilege. We have that honor of being able to enter into people's homes and meet them where they are. We also were able to purchase a mobile clinic, which also was very much about addressing the community where it is. One other program I wanted to highlight, which was sort of, there's many, many things I could talk about that we've been doing, but it's about how this department has met the community where it is and the sustainability. And one of the programs that Chief Murkison, as well as Commissioner Sana Gregory, established, which has been so innovative, is doing a firefighter EMT pathway that starts in 11th grade in high school in these communities, where we are taking, and that's the educational disparity of our community, where we go and have collaborated with the public school system so that when they graduate, they have the opportunity to have finished both firefighter 1 as well as EMT, and we hire them in our department. And so there's mentoring in addition to job offers, which, as you know, when you look at economic stability and you look at what some of these children do for their families and how sometimes they're the primary source of income for so many of these families, or at least an extremely important support mechanism, this was our way of sustaining some of that and expanding that and offering that. So then this happened. And so what do? We went to work. We have a fantastic, fantastic department, enormous amounts of experience, enormous amounts of pre-hospital knowledge. Because we're fire-based, we're very paramilitary. So there's rank structure, there's extreme organization. I mean, this is the organization that responds to tornadoes. This is a response, and a pandemic is technically in our playbook. My presence and the why it's important was that it allowed us to expand from just incidental response to management in a huge composite. So that included from the beginning. I mean, we're talking from December essentially, since I just started there full time. So this has been my year. So we've done testing, which is, we've partnered with the Board of Health. That's a picture of us going into our nursing homes way back in March and supporting testing in our nursing homes. Community testing, we've been able to ramp up mass testing events that we've partnered with Congressman David Scott. Over 9,000 community-based testing. We ran testing through cooperation with the city of Riverdale, where we borrowed one of their parking decks and had our nurse practitioners and our paramedics testing. We also did one of our ways to look at disparities and look at health access, look at educational access, and look at a community that was very much at risk was, how do we support all the other functions within that community? So we took over testing, surveillance, vaccination for every department in the county, and that's all public safety. All of our police, all of our sheriff, all of our parks and rec, all of our, when we had to vote, they were, that department, community department was under ours, and we guided them on how they were going to take care of their own and also how they were going to interface with the public. And as you know, Clayton County was on the news during the presidential election, and so it was quite important. Surveillance and education and guidance. We have been involved both with community outreaching, which includes things as fundamental as mass distribution and education at events and at any opportunity we had, as well as online town halls. Both myself and Chief Murkison, who I believe has gotten a field promotion as an epidemiologist through this, as well as radio shows, talk shows. We've established department protocols for all of our departments through this, and contact tracing and patient management. We have contact traced and managed over 2,000 of our internal department personnel. The other thing that we did, and this is more relevant, is vaccinations, which is we've established cold chain management, distribution administration, education and community outreach around vaccinations, as well as we are and have implemented mobility of locations, meaning we can get up and move. So we've tried to put ourselves in the highest density areas that have the highest SVI scores within our county, and because we're EMS, we know where the high-risk communities are. We know where apartment complexes are at high risk. We know where mobile units and large complexes have decreased access to this. So we're trying to put ourselves sort of right in the middle of that for vaccine administration. And this is my last slide, so please bear with me. We've also done an enormous amount of partnerships with purpose, with cities, City of Riverdale, City of Jonesboro within our county, with more larger scale partners, including Congressman David Scott. We've partnered with all of our departments, including our senior center, who's amazing senior department here, who have outstanding programming. We were able to reach a large amount of seniors and turn them into advocates within the community to get vaccinated. As you know, because of the demographics of our community, we have a huge hesitancy and cultural to overcome. We have a lot of conversations around Tuskegee. We have a lot of conversations around the inequities, the truth of the inequities of healthcare and the experiences of so many of our individuals when they have accessed healthcare being with demographics of either race or economy. It is not a relationship that is filled with trust or reliability. And what we've tried to do in our community is segue into what we are, which is the fire department. It's hard to find someone who doesn't like a firefighter, and use that as our entrance into conversations, as well as bridging and partnering and using our reputation to try to form some of those trusts, and we will continue to do that. But it has been an extremely difficult journey. I will absolutely be very honest with you. There's a lot of barriers, and it's extremely frustrating. And I know many of you will speak to the lack of resources and the lack of access, and it's frustrating to see that we have done with our partners. We have provided an enormous amount of opportunity for vaccinations, and that's a statement of the wealth of our country and the wealth of our resources and the wealth of our access. But yet to overcome the inequities, the history, the distrust, or just the access, just pure convenience those are the things that are in our future, and those are the things that we are looking at and what we can address. And hopefully we will be successful. We will continue. But that's our little county story and our amazing department story through this. Thank you.
Thank you very much, Dr. Reddy. And to anyone in the audience, as we go on to the next speaker, please feel free to enter any questions in the chat for Dr. Reddy. We'll be coming to the questions at the end of the 4 talks. Now I would like to introduce Erinn Bacchus. She is a PhD student in community health and health policy at the CUNY School of Public Health. And she previously obtained her master's in public health and epidemiology at Columbia University. She is broadly interested in generating and analyzing policies that address racial disparities in health, and her current research investigates policies affecting low-income housing in New York City, criminal justice reform, and access to health insurance. Today, Erinn is going to speak to us about COVID-19 and equity issues in US prisons and jails. Welcome, Erinn.
Thanks so much, Ron, and thanks so much everybody for having me today. So as Ron mentioned, I'm going to be talking a little bit about vaccine equity among US prisons and jails. Can everybody see that?
Yes.
Okay, great. So yeah, let's jump right in. So for today, I'm just going to go over a few things. The first is I'm currently working with some professors at the CUNY School of Public Health on a study that is investigating some of the experiences that folks have had inside of New York City jails during the time of COVID. And so I want to talk a little bit about that study, some of our early findings, and how that's kind of informed our views and the recommendations for vaccine distribution in the future. And then next, I'll talk about some of the current issues that I think that we're experiencing around vaccinations in prisons and jails. And lastly, talk about some of the implications for the future. So I just wanted to spend a little bit of time giving a very brief overview of the mass incarceration issue in the United States for those of you who may not be aware. The US makes up about 4.2% of the world's population, and yet we hold about 25% of the world's incarcerated population. And So we know that jail doesn't serve to improve lives, but those who are incarcerated do deserve to be treated humanely. And those who are in jail face the risk of death due to infectious diseases like COVID-19. And recently research has come about that we are finding that those who are in prisons and jails are experience 5.5 times the likely risk of being infected, but they also face 3 times the risk of death when compared to communities locally. And this is because of a lot of reasons, right? So the close quarters, the lack of access to PPE, but also to information surrounding the pandemic and its progress. And specifically with regards to jails, prisons often don't experience this, but jails in particular are very unique. So they act as a revolving door. People come and go on a day-to-day basis, and this high turnover rate has huge effects for the risk of those inside, but also for the communities outside that they return to. And this is just a brief graph that I wanted to show you. It highlights the progression of the New York City jail population from the beginning of the pandemic on March 16th of last year through May 21st of this year, so just last week. And you'll see that we started off at about 5,500 folks incarcerated. It dropped a bunch when we were decarcerating a bit in light of the pandemic. And since then, we've been on this huge uptick, so much so that we've now progressed past that point prior to the pandemic beginning. And so these are our research questions. We were really interested in how those who have been formerly incarcerated perceive that the pandemic was managed and is currently still being managed inside of New York City jails. And we wanted to know how well they perceive the jail system to protect those inside. And again, this was among New York City jail folks who have been incarcerated during the time of the pandemic. And this is our methods. It was about 12 total interviews. They were all conducted via Zoom or phone. They lasted approximately an hour, and participants were provided with a $50 incentive for the time that they spent with us. We recruited through Fortune Society, who is a reentry group, and they help facilitate folks who are reentering into the community with things like education, jobs, healthcare access, and so forth. And lastly, the inclusion criteria below. They must be adults over the age of 18. They had to have been either released on March 1st or anytime later, so encompassing any time that the pandemic was active in New York City. And they must have spent at least 10 days inside of a New York City jail. These are just some sample characteristics. The average age of folks was about 38 years old. We had 11 males participate and 1 female. Most were African American. Most spent more than 75 days inside. And most individuals, almost half of the individuals, spent their time at one particular jail facility in New York City. And these are our preliminary findings. So we're still undergoing analyses right now, but this is what we're finding right now. And a lot of folks bring up jail accommodations, right? So they bring up a few things in relation to that. Cleanliness, the inability to socially distance within carceral facilities, and also differences by facility that can make things either easier or harder for them to do these things. And here I just highlight some quotes from from some of the folks that we had interviewed. I won't read them, but they just illustrate some of the struggles that folks are experiencing inside. The next finding that we talk about, or folks talk about most, is healthcare. So they really mention how well their needs are being met inside, but also how they're being treated. So how are staff and doctors, physicians, anybody who's responsible for their healthcare, how are they being treated and how well are those needs being met by them? And again, here is another quote that illustrates that, when things get really complex inside, the correctional facility healthcare systems are not equipped to manage them. So we rely on the local communities and those systems to pick up that slack. And that includes COVID and its extreme side effects or the complexities that follow that. And lastly, folks talk about how COVID was managed. And one of the biggest things people talk about are the secretive environment and the lack of information. So especially at the beginning of the pandemic, we didn't know what was happening even inside our communities out here. So a lot of folks inside felt lost. They didn't know what was happening. Communications were being cut off. Newspapers were being clipped to exclude information about the pandemic. TVs weren't being turned on so that folks could have access to the news. And on top of that, it was really hard to get things like masks, which are necessary in our communities, but especially so in these very overcrowded facilities. And so the current issues, first and foremost, the current CDC guidelines don't include plans for vaccinating populations inside jails and prisons. And that's something that it needs to be addressed first and foremost. But in addition to that, we need adequate, consistent, but also transparent tracking of vaccination for facilities that are conducting vaccinations inside. So right now, there are some jail systems or prison systems that are vaccinating individuals, and they may be keeping records, but they're not uniform across the board. So it can be really hard for us to get a real good assessment of how well that's being done, the rate at which it's being done, and what areas might need more access. Next, the effectiveness really depends on the real world context. And what I mean by this is that some studies have shown that vaccines with lower efficacy rates, but even if they are lower efficacy rates and they are distributed in a population that is experiencing a low transmission rate, it can be highly effective at preventing infections. But contrast to that, vaccinations that have a high efficacy rate and are distributed not as widely among the population can actually not be as effective. So it's something that we need to keep in mind in order to make sure that we are not just vaccinating parts of the community or little pieces of incarcerated populations, but that it is a widespread effort that is made across the nation. And right now we know that the reproduction rate in some jails and prisons is as high as 8.4. And what that means essentially is that for every one person that is infected, they're going to infect 8 more people. And again, in overcrowded facilities like those in the US, this is devastating, can be devastating for those populations and for our local communities. The next thing that I think Dr. Reddy touched on is very prevalent inside of jails and prisons as well, is vaccine hesitancy. A lot of our jail and prison population, as many of you may know, are made up of those of low economic status and communities of color who are already disproportionately affected by both incarceration, but also by COVID-19 outcomes. So, and there's a real hesitation for folks not trusting the system, not trusting the healthcare system, but also incarceration and carceral facilities and the systems that manage them. And this is exactly why, in addition to vaccination distribution, we should still be moving towards decarceration. It should still be a priority. And some of the recent studies that have come out have showed that in combination with implementing CDC prevention guidelines, if we also incorporate decarceration efforts, it can lead to a reduction in transmission. So one study found that a 9% reduction in the carceral population led to about a 56 decrease in transmission rates. So that's a huge decrease. And if we just continue making efforts to decarcerate our systems of folks who are not a threat to society, it could have a greater benefit for public health at large. And again, not just within these systems, but in our broader communities. And lastly, implications for the future. So I just want to reiterate first and foremost, people who are incarcerated are people and they deserve equal treatment. But also the government has an obligation to provide care for those that are in their custody, right? So vaccine distribution in prisons and jails directly affect our local communities, as we mentioned before. So 11 million people about cycle through the carceral system every year in our nation. And like I mentioned before, jail systems in particular are especially hazardous because not only are folks who are being run through in and out of the jails themselves, but even those that work there, right? So guards, doctors, social workers, admin folks, everybody that works in these systems are revolving through these facilities, and it puts them at risk, but it also puts their family members at risk, their friends at risk, and our broader community at risk. And Again, Black and Indigenous communities, but also other communities of color are disproportionately affected by our carceral system, and they are disproportionately affected by COVID itself. So it is important that we advocate for vaccination within these systems, because these folks are already at a disadvantage. And by pushing for vaccine equity, we could at least help try and close this gap that we're seeing between these communities. And lastly, this could contribute to reduced health costs. So as I mentioned before, we've seen in healthcare or in carceral facilities, if the healthcare system inside is not able to manage the conditions that those experience inside, that then is the onus of our healthcare systems in the local community. And that increases healthcare costs, and that also just circles back to increased costs for taxpayers as well. So it's in all of our interest to make sure that populations like those who are incarcerated have access to vaccines. And I think all of this ultimately is why we need to be prioritizing vaccine distribution across all of our carceral systems in the United States. Thank you.
Thank you so much, Erinn. And if anybody would like to add any comments to the chat for Erinn or for Sudha, please do. We welcome those. And for people who have their hands up, just to remind you, we'll be getting to the question and answers after all speakers have spoken. So now I would like to introduce Dr. Jeremy Slack. Dr. Slack earned his PhD in geography at the University of Arizona in 2015, and he is an associate professor in the sociology and anthropology department at the University of Texas-El Paso. He has been working on the US-Mexico border since 2003, studying migration, deportation, and the impacts of widespread drug violence on immigration. His recent book, Deported to Death: How Drug Violence is Changing Migration in the US-Mexico Border, explores issues such as kidnapping, forced recruitment, extortion, and asylum. Today, he's going to be speaking about how COVID-19 has ended asylum on the US-Mexico border. Welcome, Dr. Slack.
Thank you so much for having me here. It's a really interesting panel and a lot of amazing issues. It's interesting because I'm also working on a project to do wellness checks with individuals who are in immigration detention. So it kind of fits very nicely, but it wasn't what I was planning on talking about today, although we can maybe address some of those issues in questions. But what I really wanted to talk about today is kind of the current situation that we're facing under the Biden administration and how we got here. So the big issue is that along the US-Mexico border, we really kind of moved away from undocumented immigration and moved towards asylum adjacent migration, starting in about 2014. And so this is when we started to see individuals from Central America and especially families and women and children applying for asylum. And this changed a lot the kind of structure of how the US-Mexico border functions, which had been kind of primarily set up to apprehend mostly adult male Mexican nationals and return them to Mexico very quickly. And we started to see this increase in people that had different backgrounds, which really sparked this notion that actually these people have a legal right to be here. They're fleeing violence. There is a lot of international law that supports their claims. And so even though the court system itself is quite arduous and difficult, the fact that they're physically present on US soil and need help means that they automatically trigger protections for asylum. However, under the Trump administration, we saw multiple attempts to end this system, right? We saw several asylum bans. The first was to ban people that cross between ports of entry to apply for asylum, which was struck down by the Supreme Court. I was an expert on that case. And really because of the fact that Congress has essentially set up rules for what happens when you apply for asylum between ports of entry versus at the actual gates where people come into the country. And then we saw another asylum ban that was successful in being upheld, which was that people had to apply for asylum and be denied in a third country before they're eligible to apply in the United States. But what that did is essentially just kind of took some of the legal options off the table for people and didn't stop people from coming and applying for asylum, usually under the relief under the Convention Against Torture. And then finally, we saw kind of this, what was probably one of the most brutal policies of the Trump administration, which was called the Migrant Protection Protocols. And these were essentially this program known as Remain in Mexico, where people are sent back to Mexico after applying for asylum to go through their court process in a very strange way, where they kind of come to the US, come to the bridge, go to a court in the United States, and then get sent back to Mexico while they await their hearings. And this was a process that was already drawing out for years when COVID hit, right? And you saw all these cases frozen and people stuck in Mexico. And this is one thing that the Biden administration did address quite quickly, not maybe as quickly as many people would have liked, but they said, okay, everyone who's in the Migrant Protection Protocol program, whose cases are still active, they can come to the United States. And so, they've been processing people and sending them to the United States in a fairly orderly and easy fashion. However, in March of 2020, we saw the invocation of what was known as Title 42, a health restriction that effectively stopped anyone applying for asylum. And so since March until right now, we've essentially seen asylum suspended on the US-Mexico border. And so really this idea that if you arrive in the United States, if you're physically present in this country, that we have to help you has been kind of gutted in this current moment. Now, Title 42 comes from Section 265 of US Code Title 42 and permits the CDC to basically prohibit the introduction into the United States of individuals when the director believes that there is a serious danger of the introduction of a communicable disease in the United States. Now, it's a very obscure law. It's something that doesn't get used very much, and there's been a lot of controversy about whether or not they can actually do this to mass groups of people, especially when they're kind of discriminatory about one group of people versus another. But also a lot of lawyers have done some great research into how this started, and it really didn't originate in the CDC, right? This came from the Department of Homeland Security, from Customs and Border Protection, trying to eliminate asylum. So really kind of fit into the goals of the Trump administration, which are, were at their core were to stop legal migration, right? It really had very little to do with undocumented migration at all. And so what we saw is this usage of this kind of obscure law to end asylum. And the Biden administration has kept this going, right? They have maintained this, and now they softened it a little bit by allowing unaccompanied minors to apply for asylum. And so what that did is this creates this large number of unaccompanied minors, usually teenagers, that are coming to the United States and applying for asylum, most of whom have family waiting in Mexico and waiting in the United States, right? However, this creates a huge issue because there's a lot of things you need to do under the law for unaccompanied minors in terms of how you reunite them with sponsors, how they're detained, how they're moved. And so it creates this really, really large logistical problem here on the border. And they've also, although it's unofficial from, a lot of the work that I've done and other people have done, Cubans are being allowed to apply for asylum, Venezuelans and Colombians, but Central Americans are not. So Central Americans, particularly Guatemalans, Hondureños, and Salvadoreños, Honduras and El Salvador are being sent back to Mexico to wait, right? And so you have this situation where there is a lot of doubt about what the law actually states because there's a lot of discretion at the individual level. However, we see these massive groups of people again being removed to Mexico and stuck there with no real recourse for seeking help. Now, what this has done is it's kind of changed migration along the border back to an earlier period, to really kind of a pre-Obama era when it was mostly adult single males crossing the border, trying to evade detection. And this is what we're seeing in the statistics right now. And so I'm sure people are hearing a lot of information about record numbers of people crossing the border. There's a lot of people coming, and it's not quite true. It's certainly a busy year. But for example, in 2019, about 1 million people crossed the border. Of those, almost none of them crossed multiple times, right? They were almost all seeking asylum. And so when they cross the border, they apply for asylum, and their case is going to drag out for years. Now, right now, what we're seeing is, I hate using the prison term, but it's the term that's officially used in statistics, is a lot of recidivism, people crossing multiple times. And so you see that the apprehension statistics, or they're sometimes being used as encounter statistics right now, are kind of inflated because there are multiple people counted multiple times, right? And so what's happening is you see this kind of diffusion of who's being given access to asylum and who is crossing the border and how, which has given rise to a lot of abusive scenarios along the border. For instance, last week I was doing an interview at the government shelter in Juarez with a woman, Marisol. She's about 31. She had 3 children. She was from Huehuetenango, Guatemala, and her husband had been threatened by the Maras, by the local gangs, and had been forced to flee into the United States. And he had gone about a year or 2 earlier than her, and he'd been able to get to the United States with their eldest daughter, who was also being threatened. However, during the hurricanes this last year, she lost her house. And so they ended up selling their property and trying to reunite with her husband with the 2 children, 2 youngest boys. And they eventually crossed the border in Reynosa. They had a horrific journey. And when they came and they applied for asylum and they asked for help from the Border Patrol, they said, okay, yes, we'll take you to where you're going. And they put her on a plane and they said, where are you going? And she said, I'm going to Miami. And they said, okay, you're in Miami now. And what they actually did was they dropped her off in El Paso and Juarez. And so she said that when I saw the Mexican flag, she broke down and started screaming, and she could not believe it, that they were so close and they had been lied to. And this was an extremely common scenario that we were hearing in the shelters, is that people are actively being lied to and being told that they're being taken to their destination, that they're being allowed to kind of pursue these claims, and then dropped off in a city. And the other thing about this that's important to know, Reynosa is border with McAllen. That's almost 1,000 miles away from here in El Paso. So they're being taken to a completely new city, a completely new part of the border that presents a lot of dangers and challenges. And Marisol has been spending about 2 months in this government shelter, which is, they're doing the best they can, but it's an area that's has very limited COVID protocols. Everyone who comes in there has to spend a week to 2 weeks quarantined in either this place or there's another hotel where they have essentially no entertainment, nothing. Some of them have a shared TV they can use in some of the rooms, but there's no internet, there's nothing like that. Marisol's youngest son got incredibly sick from the experience in Border Patrol custody, which was he was kept in this processing facilities that are extremely cold. They're called the hieleras, the ice box, and he was very sick, and she couldn't get out of quarantine to seek medical attention for him. But she's been in this area, and the shelter there it's a maquila, it's a factory. So it's a gigantic building filled with bunk beds, basically as far as the eye can see. And they luckily have enough space to have some quarantine areas for COVID, but also for chickenpox, which has been a big problem there as well. But it's extremely challenging. And you have this massive group of people that's stuck on the Mexican side of the border, where there are no access to vaccines and very little access to PPE and very little access to COVID testing, right? And so, despite a lot of these promises from the Biden administration, we're seeing this as a huge challenge and a huge kind of way that international human rights have been violated, and a destruction of people's basic need for protection. And so something that I really kind of think would be great to talk about in this context with so many other people who have different experiences providing care and thinking for solutions to how we deal with health, not only for among these issues related to the pandemic, but for the future going forward. And I want to thank the National Science Foundation and Context and PIMSA for some funding of this project, but also my friend and colleague Murphy Woodhouse for his photography to give everyone a little taste of what it's like down here at the border. Thank you so much.
Thank you, Dr. Slack. And to the audience, once again, please feel free to enter questions into the chat for Dr. Slack and all of the other speakers. We'll go on to our final speaker of the day. Dr. Karin Slowing is a medical doctor at San Carlos University with a master's degree in public health for developing countries and special training in social research methods. She also has extensive experience as both governmental and international development assistance organizations with coordinating development programs that involve dialogue and advocacy with a variety of social, public, and private actors in areas of high social sensitivity. Dr. Slowing is the founder of Laboratorio de Datos GT, a citizen voluntary organization that has been following the COVID pandemia in Guatemala and the Central American region. And she is here today to speak about 1 year of pandemia in Central America. Welcome, Dr. Slowing.
Thank you very much. I hope everybody sees the screen.
Yes.
I will try to update you very quickly on what is happening in Central America regarding the pandemic. I will go straight into the point and have some key messages I want to share with you directly. And the first of all is that we had not a very promiseful situation when the pandemic started. Most Central American countries were less than ready for a challenge of this size. Here we have a slide of a report that was issued in 2019, which is the outcome of a study that was assessing the preparedness that different countries had to face a pandemic, an epidemic in the world. And as you can see, the Central American region altogether were not prepared, but particularly the Central American countries were less than prepared for that. Here you can see an extract of this report, and you can see that you can divide actually Central America into regions or two sub-regions. One with Costa Rica, El Salvador, and Panama, which better position in this index. And then the rest of Central America, mainly Nicaragua, Guatemala, Honduras, and Dominican Republic, which are not rating very well in that regard. So we had a pre-pandemic condition that wasn't very good. And there are historic structural problems behind that situation that explain this poor readiness to manage the pandemic. I will focus briefly in three areas that are particularly important for this discussion and for understanding what happened and what is happening in the region. First of all, the health services related situation. We have fragmented services, lack of universal coverage in most countries, deteriorated public health capacities and epidemiological capacities. We have socioeconomic problems, very heavy ones, such as extended poverty, huge inequalities, racism and discrimination, low levels of education, and a very strong influx of religion in the country that makes it very difficult to inform and communicate people about science and facts. And we have a more recent trend, which is also affecting very much the way we are able to manage the pandemic, which is that this sense of the political establishment is increasingly losing the purpose of working towards the common good. And instead, we are having increased authoritarianism, in the region that despises evidence and science, and therefore decisions around how to manage the pandemic have been very complicated to implement. The main measures altogether, this is a summary, of course, taken by Central American governments can be organized or categorized in 5 different areas. The contention measures, as we call them, which is all measures regarding to restricting mobility and have affected some civil rights, basic liberties of people. Epidemiological measures, mitigation measures, that is to improve the response to the sick people, the people with COVID, social protection measures, and political measures. And that has a lot to do with negotiation with the Congress in different countries to have financial support packages to manage the pandemic in particular. This kind of policy mix is similar to what many other countries have done. However, we are trying to systematize how this policy mix differ from country to country. What we can mainly see in the CA4 countries, we call them Guatemala, Honduras, El Salvador, and Nicaragua, is that contention measures, measures to restrict the mobility of people were very much favored, and they were very much in tone, in the liking of authoritarian governments that we have, but they were not necessarily smartly applied. They were necessary, but not smartly applied. There was less emphasis in managing the pandemic with strong epidemiological measures and with strengthening the health services. So we have had, peaks of saturation of hospitals and that with relatively small amounts of people demanding the services compared to what happened, for example, in your country. But this has to do with the structural weakness of our systems. Poor use of data to inform decision-making, and very little socioeconomic support to individuals and households and businesses that had to be kept isolated during the worst parts of the pandemic. There are specific contents of each policy that have varied as well. There is a strong resistance altogether to provide public access to information around the pandemic. So we are always, looking for the data and trying to get the data to have a panorama of what is happening in the region. But according to Transparency International, there is a common pattern that we can see, and I hope you will see in the data I'm going to show very shortly. Less transparent countries tend to show less registered cases. And that is the basic for some of the governments in the Central American region to claim success in management. And corruption has taken a big toll in our countries because we have invested and made a financial effort, but people still have not adequate equipment to deal with the situation. And also with vaccines, we have a very big problem with vaccines, access to vaccines. This is an example only of how we are trying to systematize and categorize the type of measures and when they have been applied and what are the elements that are involved in that. This is for Guatemala. This is work in progress. I'm just showing that to see the importance that it has to understand what has been done in the region. And we also know that it's not only about policies applied and implemented, but also we think that the reason why Central America hasn't seen outbursts, like for example in Ecuador, Peru, or Brazil, has to do with some other factors. We are hypothesizing about them, some of them with the demographics, rurality, and so on. As a result of this situation, we have a double epidemiological pattern in Central America. And this has to do, for example, you can see the trends for Costa Rica and Panama. They are consistently different in the number of cases. They report more cases than the rest of Central America. This is also has to do with the amount of tests, that the testing pattern that has been applied in the region. And you again can see that Panama and Costa Rica and El Salvador have done a big effort to test the population. So there are more accurate data on what is happening in those countries in comparison to the Northern Triangle countries. And we have the same thing with the deaths in the region. We have reports of deaths, sorry, this is the death one. But there you can see again that there are more accurate data for Panama, Costa Rica than for the rest of the region. However, when you look at the excess mortality analysis in the region, you see the opposite thing. And you can see, for example, Guatemala having an extreme peak that is not related with the former slide I was showing you in yellow, where you could see Guatemala with relatively a low death rate. So did we do better or not in Guatemala? Well, we think we haven't done better. And especially when you look at excess deaths analysis that we have been doing for the country, you see that there is a huge of underreporting that is affecting all age groups and all population. And we don't have the epidemic under control. You can see here just for COVID cases, that is a systematic reporting that is being shown in this yellow line just for COVID, but a very big underreporting for other mortalities. And we still don't know what they account for, if they are really COVID cases or there are cases because of other diseases that have not been addressed during the pandemic by the public health system. So this is briefly the situation in the country. It's still a story yet to be written and told properly, but I thank you very much for having this opportunity to share this data with you. Thank you.
Thank you very much, Dr. Slowing. So now we'll go on to the question and answer period. And Dr. Puentes and Dr. Sheffield are going to help me out. We're going to field the questions from the chat, and we welcome more questions as we go on. First question for Dr. Reddy. What lessons have you learned working with the fire department, which can be translated to the police department, which has struggled to balance their enforcement work with the social service sector's intervention work?
That is that's a loaded question. One of the things that we benefit from here in this particular county is that our fire chief, Chief Kevin Roberts, is also equally very innovative and forward-thinking, has a lot of work around community policing and looking at interventions that that are focused on supporting the community as a way of intervention and management. Everything from allowing the police force to reflect the actual community to approaches and the type of priorities the officers are given. And with that being said, for us, we've been fortunate in that there has been absolutely no disruption from the police in terms of their ability to come to us to ask questions, their utilization of the same protocols that we've used, both for their in-staff as well as how they manage anybody that is arrested or incarcerated, have been applied universally with an enormous amount of detail. With that being said, that does not include, we have a sheriff's department and a corrections department as well. So there's different areas in the county. We have had communication with corrections that has also been looking at how do we look at preventing the officers from bringing in COVID to the incarcerated population, which is truly going to be the biggest vector, correct? And we've done continuous testing of these officers, their contact trace, and that we document that as well. And that has been integrated and supported by our Board of Commissioners and oversight from that local governmental level. So what lessons have been learned has been a political and a cooperation that has been supported by our local jurisdiction, our Board of Commissioners, that has allowed what we've done and what we've said is best practice to be translated, which I think has affected, I believe our corrections has a private contractual healthcare provider. We've been in conversations with them as well, especially around vaccination. So I think because of that political will, because of the goodwill that we have created and the ability for us to be so transparent and the support of our commissioners and our local government, it has translated quite well.
Thank you. Dr. Fuentes?
Sure, this is a question for Erinn. Thank you for highlighting the need to decarceration. I was wondering if there was any gender discrimination when distributing resources to incarcerated populations.
Thanks for this question. It's a really good one. With our experience in our study, and specifically, we weren't able to find that out just because we didn't have enough folks from the women's facility that could speak to those experiences. But just going off of historical perspectives, those who identify as women tend to utilize healthcare systems at a greater rate than men. So I would imagine that if healthcare is lacking inside of male carceral facilities, that the same is probably happening in the women's facilities and might be impacting them more so. However, that said, we do know that the majority of the jail and prison population are males. So it's hard to say, how those are distributed based on whether it be where the facility is located, the impact of the size of the population in each facility. I'm not 100% sure, but I would imagine there might be some disparate effects leaning towards male facilities having more resources, but I'd have to look more into that.
Okay, actually, Erinn, there are a couple of somewhat technical questions, and I'd like to combine it with one other question. I was trying to write it down while you were speaking. You gave us a very kind of remarkable statistic, and it was, I believe it was a 9% rate in the incarceration rate would lead to what was the actual impact?
Yeah, so what we're seeing is that a 9% reduction in incarcerated populations is associated with a 50% decrease in the transmission rate, which is incredible. Again, this is a very new study, so I think it might take some time for us to see replication of that and what that looks like elsewhere. But yes, that was what was found.
Yeah, that's extremely remarkable. So I'll just add the other couple of technical questions that came in. One person is asking us about the comment on the impact of visitors, right? You were mentioning the spread going the other way, right? People released from prisons, but what about people visiting prisoners and bringing COVID into the prisons? Do you have something to say?
Yeah, that's also a really great question and definitely something to consider. The reason I didn't really talk too much about that aspect is because pretty early on when they started, DOC started implementing restrictions, a lot of carceral facilities were actually stopping visitation rights. So they weren't allowing folks to have physical visits and even to have telephone visits just because they would be within a communal space for a long period of time. So I'm not sure how relevant that is for the earlier periods of the pandemic, or I guess I should say the mid periods, because early on there were no restrictions and there were no real guidelines surrounding that. So again, I think this is something we'll have to wait and see. But even so, because of the lack of documentation and tracking and data collection, I'm really not sure that we would ever get the answer, a clear-cut answer as to how that's really impacting folks. But I'm sure that there was some impact and some effect, especially when visitation was allowed. But like I said, that was stopped fairly early on.
Okay, thank you very much. Lucia, did you want to go with the next question?
Sure. I was actually
I mean, I can ask next.
setting up a question. Yeah. Do you want to go, Allison? And then, because I have another question for later.
Yeah, we had a question for Dr. Slowing. So do you believe, and it leads off, lots has been said about developed countries taking over most of the vaccines. Do you believe Central American countries have any other opportunity other than just waiting for the vaccines to come to those countries?
Well, in fact, again, we can see the difference in the region, in the sub-region. We have Costa Rica and Panama, who dealt efficiently with bilateral negotiations regarding vaccination and access to vaccine specifically, whereas Guatemala, for example, and Honduras made a very late bilateral action on that. So they have had less access to vaccines apart from the PAHO, the World Health Organization mechanism called COVAX. So I think in the way that developed countries finalize their minimum coverage, population coverage, at least reaching 70% of their populations vaccinated, and more effort is put, for example, on behalf of the United States to support the COVAX mechanism, I think that in that way, we will be able to have more access to vaccines. However, there is a complexity in this that is the challenge that we have, that our health services are able to vaccinate, which is the critical challenge at the moment. We have some access to vaccines, but the rate of vaccination is very slow, especially in Guatemala and Honduras. We have a different pace in Costa Rica because they have a better health system. So this difference in the structural problem of our health systems are making a huge difference. It's not only access to vaccines.
Okay, may I? I'm not sure which one of us is going to go next with the question, but if I could just jump in, I'd like to make a connection between something you mentioned, Dr. Slowing, and something you mentioned, Dr. Slack. So, Dr. Slowing, you mentioned authoritarianism, and I think that theme has come up multiple times during the day, and how governments may sort of there are certain lockdown policies that actually fit well with authoritarian agendas. I'd like you maybe to speak a little bit more about that, if you would, and then I would like to ask Dr. Slack if you tie this idea of authoritarianism in any way to the ending of, or the reasons that asylum ended at the border under the previous administration. And if you could clarify for us just how much that has and has not changed with the new administration. So sorry to drop a double-headed question in here, but I thought it would sort of spur some questions across. Dr. Slowing first, maybe?
Yes, thank you. Well, I have to start by saying that contention measures, as we call them, restricting mobilization and so on, were important and are important to manage the epidemic. So that's not the problem in itself. The problem arises when governments rely mainly upon those measures instead of applying epidemiological measures to manage the pandemic. And that is what has happened, at least in Guatemala, El Salvador, Nicaragua, and Honduras very strongly. So restriction of mobilization, lockdowns, toque de queda, I don't know how to say that in English, but it's when you restrict the time where you are allowed to be outside, to a certain period of in the day. So this kind of curfew, thank you. These kind of measures have been very strongly applied and have affected particularly the rural populations, which were not that affected by the pandemic, but still had to follow. So these elements, we question that they were too strongly and mainly also used to deter people, for example, from protesting against the bad management of the pandemic or the lack of access to vaccines, because we have restricted authorization to demonstrate, for example.
Thank you so much.
Yeah, it's a really interesting question. I think that there's parts of it that I might have some thoughts on, and then I think there's parts where I probably don't kind of know the answer. I think it's no shock to anybody that the Trump administration exhibits a lot of authoritarian tendencies, and I definitely think the ability to have such a brutal, wide-ranging denial of asylum was rolled into that, right? And I think, one of the things that was important to note is that, everyone was facing travel restrictions in March of 2020, right? It was a pretty common across the board thing, issue throughout much of the world. And I had the question at the time is this going to be some sort of egalitarian limits on mobility, or is it going to follow the way that it usually follows, which is, class and race sort of determine who is allowed to move and who isn't. And of course, it was the latter, right? And so we see this kind of border closures here never really resulted in a closure for US citizens and residents, right? So US citizens and legal permanent residents were able to travel to Mexico and back and forth, and their travel was deemed essential by virtue of the fact that they're citizens, right? Now, a lot of those restrictions are still in place for many other types of visa holders along the border. And a lot of it has to do more with economic and spending issues than it does with pandemic issues at the moment. But it's a big problem too for, the vaccine issue, because if people are allowed to cross, they can get vaccines here, and that would help our shared community on the border greatly. But they're restricting this a lot. So that's not considered an essential travel if you have a vaccine appointment, unfortunately. But we do have this kind of authoritarian, heavy-handed way in which you saw these big changes happen, and you see them happen from a very top-down way. Like I was saying, with the CDC not originating this call to end asylum, but it coming from the Department of Homeland Security. That certainly, I think, is something that has hallmarks of an authoritarian change that really fits in with the broader agenda of the Trump administration, hand in glove. On the other hand, right now, I see this kind of enormous task of trying to figure out how to unravel some of these programs, as well as the kind of traditional fear that we've seen in the Democratic Party of being seen as weak on immigration or have some sort of kind of failure on borders that could hit them politically. And so we do see that kind of hesitation from the Biden administration. And I'm not really sure what that's going to lead to. It hasn't been great in the past, right? It wasn't great under the Obama administration. I think that they kind of made some great moves at the beginning of their administration in terms of trying to put in a moratorium on deportation and ending MPP and ending it in a really kind of clear and orderly fashion. But, regardless of what they do, people are going to think, oh, this is a better time to cross the border because there's a better president in charge. And then Biden kind of gets hit with that. If it were, up to me and I was trying to tell them how to avoid the political blowback is do something that doesn't push people through the deserts, right? Because that's what kind of is able to be used as fodder in Fox News. Let them sign up, let them just walk through the port of entry, go to where they're going, getting on buses. That's not a crisis in anyone's mind. People have clean backgrounds, they've done the background checks, they can do them quickly. About 90% of people have never even been in the United States before. And we're talking about women, children, and families mostly. It's a pretty easy situation to handle if you do it in a humane way without trying to sort of reinforce these old authoritarian ideals that the only way that we can secure the border is basically to punish everyone who tries to come here, right? And make it as horrific and horrible as possible. And so this is why we have such a large immigration detention population in the United States, which has been another huge issue for COVID-19. So, hopefully we'll see this unraveling, but a lot of times when that power is set up in these organizations, they don't want to let it go. So it is a big challenge.
All right, thank you. Thank you very much for adding that detail. Sure. Dr. Sheffield, Dr. Fuentes, any questions?
I see another question for Dr. Karin Slowing. It's presidential elections will happen in both Honduras and Nicaragua later this year. Has COVID impacted these processes in any way?
I don't think it will impact, honestly. Situation is, the way these governments are functioning will enable people to cast their vote. And as far as I understand at the moment, there will nothing be, to there are no concerns regarding COVID and elections, and I don't think that will affect.
Thank you. There's a comment in here, and I wonder if anyone has a perspective on this. Robert Fulalove says, I teach in the Bard Prison Initiative, and it's interesting to note that June 1st, my colleagues and I are going back to teach classes face-to-face, largely because the vaccination rates and the fact that so many people have been infected, there's a sense that a level of herd immunity has been reached, at least in that prison. Erinn, has any of this discussion about herd immunity in the prisons come across your radar screen?
Not yet. And I don't know if that's because I have seen that folks are talking about herd immunity in the sense that, you know, everybody's already been infected in jails, and so they're already immune to it. How true that is, I don't really know. Specifically in New York City, you know, there have been a lot of infections, but again, these are New York City jails, so folks are coming in and out. So whether those, you know, people who have been infected inside are leaving on a, you know, through this revolving door, like I've used many times, and new folks are coming back in, that's not really going to affect the transmission rate inside. Dr. Bob, I think you're referring to prisons specifically, and that's a big difference in the sense that folks aren't going to be as moving as back and forth, through the system. So I don't know. I think that would be a really interesting thing to see. Again, this is why data collection, data transparency, and uniformity in data collection is necessary for us to be able to better articulate and sort of predict what this might look like. Because if that is true, that's helpful for us to know, and also for folks like Dr. Bob who are going to be returning to these places that are high risk.
And oh, sorry.
Oh, no. I was just going to say, I wasn't sure if Dr. Bob had anything to add, but okay.
Yeah. I wonder, Dr. Slack, if you could also then speak about the asylum centers, what the transmission rate is like in the asylum centers, and maybe you could even give us a sense of the volume, the number of people altogether that are in asylum centers in the US.
Sure. Yeah. I mean, it's changed a lot, and I would say in terms of the transmission rate, excuse me, it's been very difficult to access that information. So lawyers have sued ICE through Freedom of Information requests to get some of this, and they've gotten some bits and pieces of information, but they've been blocking it on grounds that it's national security related. Right. So typically, kind of one of the big challenges that a lot of immigration, lawyers, advocates, and researchers face is that these immigration detention facilities fall under a Department of Homeland Security. And so you don't even have as much transparency, which I know is extremely limited in jails and prisons. Right. And so access is extremely hard. And they found like huge pockets of transmission, especially in the El Paso Processing Center, which is in the municipal grounds, which gave them a little bit more leeway to request that data. There's two other facilities here that are outside of the municipality, one in Otero, New Mexico, although it's only about a half hour from the city, and the other one in Sierra Blanca, which is about 2 hours away. And so these facilities are kind of notorious black holes where people don't really know a lot about what's happening. And there was kind of a fluctuating population a lot. So, we were looking at about a population of 40,000 people in immigration detention in the country before COVID hit. And so we saw some of this decarceration impact here, but it was mostly because people kind of cycle through those detention centers and they're not adding new people in. Right. And so the only people that were getting added into these facilities were people that were living in the United States and were apprehended on a removal order. They weren't letting new people come in, which was the kind of traditional mechanism which does this. Now, even in the broader scheme of things, no one's ever been able to figure out who gets sent to the immigration detention and why, right? It's been kind of described as a game of duck, duck, goose. So people come in, they apply for asylum. Okay, this group will put in the detention center. Are we out of beds? Okay, we're out of beds. The rest of you can go. So it's a very strange system here. And so within that, a lot of my students were doing wellness check interviews through a local advocacy organization to see what the conditions were like, right? And so they found a lot of issues of lack of PPE, lack of separation, right, within the pods that people are in, a lot of people coming in and out, lack of masks. They had very strange cleaning protocols where they would kind of force the detainees to clean, and you know, sometimes make them pay for cleaning supplies as well. So, you know, these are privately run facilities. And so we've had these huge issues. I'm sorry I don't have good numbers on exactly how much transmission is had, but I don't think we actually know that. And often what we've seen with immigrations and customs enforcement is that they don't keep track of data that they don't want people to have. And so I suspect that that will be the case as well. But it's a huge situation. And then one of the big fears people have too is, okay, what's going to happen if we end something like Title 42? We don't want that to become a detention camp, right? We don't want that to become a huge way to increase a lot of these facilities that have been at least down some. And so finding a way to do that that's humane and responsible and safe is really important at the moment as well.
Yeah, I
Thank
just,
you. Oh, sorry.
sorry about that, Ron. I just wanted to piggyback after what Dr. Slack just said. I actually just found a lot of times they will lump in ICE facilities with jails and prison facilities. And I don't know if this is relevant to that, whether that it's inclusive of that or not, but a new paper actually just came out today, I think, where they cite that at least 661 COVID cases have happened inside New York City carceral facilities. I mean, sorry, not New York City, United States carceral facilities. And so just, you know, relaying that back or relating that back to that question of herd immunity, we incarcerate about 2.2 million folks, right? So we're nowhere near herd immunity if we're looking at it in that regard. And then similarly, there have been about, I think that the statistic is like 135 folks from, there's one independent sort of organization that's trying to keep track of vaccination rates, just gathering information from various centers. And they've seen about at least 135 folks, or a little over that, have received at least one vaccine. So that's not promising in any regard. I would imagine that that probably is fairly similar among ICE facilities as well.
And I think working in risk communities that we have within the county, that that conversation as being even a possibility without the appropriate testing, the data is extremely dangerous, because given the proportion in the communities that are minority, that are and including the heartbreaking ongoing activities at the border, and then how that ends up mixing and how that ends up going through is very dangerous, because I know what ends up happening at our level within just a community that has connections to both these systems is then it substantiates and possibly distracts from the idea that you do need to get vaccinated, that you do need to access that. And that's a very dangerous undertone that has repercussions across the board, which I know this has been a pandemic of misinformation, but the fact that it's out there is very concerning, because again, based on what Erinn said, the statistical probability of that occurring is just with the rate of mortality, the rate of morbidity, just from what I can tell you, because we obviously just at a grassroots ground level, we facilitate transportation out of our jails from our EMS side of the house, and it wouldn't reflect those numbers, which it's a young population, so there's something to be said for that. And then if you're looking at high morbidity and mortality, those we would touch on. So just allegorical, did I just use that right word? Sorry. Word, I don't think that it, just pattern recognition, I would find herd immunity to be very unlikely in our incarcerated population.
Great, thank you, Dr. Reddy. There are some more questions coming in the chat, but I just wanted to revisit something you said, Dr. Slack. I think that metaphor of duck, duck, goose is actually really quite a compelling one that I think probably the average US news consumer has no sense of. And so could you clarify a little bit for us? There's this kind of random sense of who's going to end up in an asylum seeking center, and the other people will then be, are they processed and released, or are they returned? If you could maybe just explain that a little bit. You mentioned not having very specific data, but that metaphor might actually be more clarifying than anything else.
Right, yeah, I mean, this has been a huge problem, and this is one of the kind of underlying things that was exposed in the Trump administration big time, is that there's a lot of random punishments distributed among immigration officials. And so the idea being that, say before COVID, before Title 42, they would apprehend a group of 1,000 people and they'd say, we have 300 beds, we fill up the 300 beds, the rest of you get what's called an NTA, a notice to appear, basically a piece of paper that says, show up at your court in Atlanta or New York or Los Angeles, check in, and you'll be given your papers and you get a work permit, and you basically kind of have to follow your case in that court setting. And so you might get that, or you might wind up in detention. And so sometimes detention is the result of what's called a negative credible fear interview, right? So which is the first step in asylum, which is essentially a 10% likelihood that this person could qualify for asylum. But usually most of the people that we see in detention have not had their credible fear interviews yet, right? So we were doing a project that was court watch. So my students and I would go into the detention center here in El Paso that has the court inside the detention center, right? That's how they function. And these are open to the public, but the public doesn't go. And so you see this often. You see people that are, most of the people there have never been to the United States, don't have a criminal record, and don't have any reason to know why they are being detained. And then you see huge groups of people that are released. And so you see this with the Remain in Mexico program, a lot of people randomly getting put into that. And you're seeing this suspicion now, right? I was with a bunch of families and they got let through, and now I got sent back to Mexico and I don't know why, right? And so there's a lot of discretion that happens. And what it does is creates this atmosphere of doubt. And I think this was something that the Trump administration failed to consider, is that I would have these conversations with people saying, you know, it's really dangerous and really bad. And they would say, God is with me and I will be one of the lucky ones. Mm. And so it really did nothing to break people's resolve. And I think at the moment, that's the other reason why you're seeing people keep going, keep trying, spending lots of money from smugglers to try and cross the border, is because they do see that there is this element of luck that plays into this. And, you know, I think this kind of fits with the broader way people have dealt with the pandemic and dealt with these difficult circumstances as a whole, is that you see so much information from the people that you know, information from the media, information from other sources of things working a different way than you see. And it's really hard to wrap your mind around that, you know, as anyone. And so I think that there's a lot of people that are saying, well, this is my option, this is what I'm going to do. And they're kind of stuck in this situation where they have very low likelihood of success, but they're willing to keep doing it anyway. And they take huge risks because the risk of being sent back home is even greater.
Correct.
Yeah, and this is what we heard this morning too from the South African speaker, who spoke about the crossing of the border there. So thank you very much, Dr. Slack. Lucia, did you want to field that other question?
Yeah, actually, this is for Dr. Reddy. You spoke about partnerships for purpose. And so can you speak about why community and corporate partnerships are so important pre and post COVID?
Sure. I think that's an interesting question because it's also very American. It's very American in that it's a conversation, especially within the context of public health, that's manifested in a unique way during this pandemic. It has become important. My training in public health, the history of public health, and the nature of how we implement public health in the context of health as a social justice, it is kind of where I've come from, and that's what I've been raised on and still fundamentally am rooted in. However, a necessity and you also in public health, as we've seen in all these different environments, needs to drive the services that are provided to the communities that we serve. And so I think community and corporate partnerships, especially in this country and especially in the context of contribution to the community in terms of obligation, to the beginning understanding of and how long this will last and where this will go is questionable. But the idea that corporations, we're not going to get into the whole Supreme Court corporations as an individual entity conversation because that's a big one. The idea that they are connected to that. I think the partnership's very important. I think for our community being so close to a metro Atlanta area with access to and foundational funding is going to be, and to be honest, right now, if you look at the landscape of how we're addressing vaccinations, if we're looking at the landscape moving forward, we're relying on that. We're relying on messaging from corporations. We're relying on companies like Delta saying any new hires require vaccinations. This is the pact that they've made with their individuals that they hire, with the communities that they serve. You have to wear a mask when you come in. These are being enforced because at a granular level, they can enforce it. We don't have a national mask mandate. We don't have a national vaccination mandate. And yet, and we have such a culture war going around all of these things that in a strange twist, and although it's not strange, it's explainable and has a lot to do with how this was addressed during the last administration and the politicization of something that is purely public health and the consequences thereof. But we are relying on that corporate initiative of taking on some of that burden of seeing what is good for individuals within their organization, which, you know, that's again a different discussion. But as a community member and as an advocate for my community, it is going to be important. How I partner with businesses, how I partner with political entities is vital, because at this point they have a larger ability to mandate. And so if I can support that as a community advocate, I'm going to, because I know that's the right decision for this current time. So they are valuable, and because their advocacy is in the right direction from a public health context, it becomes very important to support that.
Thank you. Yeah, I guess I forgot to mention this was a question from Joanne Sutherland. So just to give credit to the person who asked the question.
Yeah, it seems as if that could be an entirely other panel, the erosion of the public and of the whole public sector. I just wanted to touch base with something Dr. Slowing put in the chat. this is really a startling statistic or a bit of data here. So 8 million doses have been paid for, but only 100,000 doses have been received. Could you maybe speak a little bit to that? That's quite startling.
Well, it's a bit embarrassing actually, because you know, our government really didn't begin negotiations to purchase vaccines until late September last year. Whereas, for example, Costa Rica started, I think, early April to negotiate bilaterally with Pfizer, Moderna, and whatever. So that is the first thing. And then the Ministry of Health began negotiations on its own and they don't have skills to do international purchase and international negotiations, especially with pharmaceutical companies. So it's a very asymmetric situation. So when they finally started doing negotiations, they end up with Sputnik, because Sputnik was supposed to combine certain characteristics that that enable our health system to manage that vaccine, especially with the cold chain. You know, you need certain, you know, freezing conditions and cold conditions to keep the vaccine, and our health system didn't have enough capacity to accommodate, for example, Pfizer requirements. So we went with Sputnik. Sputnik said, yes, we're going to provide you. So they signed a contract, but they signed the contract and they didn't negotiate the calendar, the schedule for the delivery of the vaccines. So now they are negotiating that, but they have paid half of in total, they negotiated the contract for 16 million doses. That is more or less what we need to have for 70% of the adult population to be vaccinated. So, you know, that was the only option on one hand, but poorly negotiated. So when we started to press, you know, as civil society to find out what had happened with the vaccine, it ended up that they didn't negotiate a timetable for the deliveries. So we're pressing, and now the Sputnik, the Russian government has come in and they have sent the first 100,000 doses in 2 sets, 50,000 first, and just a couple of days ago, another 50,000. So we still don't know when we're going to get the main lot of vaccines and how. And so it's a very embarrassing situation. And there was an intermediary enterprise, a business. And we also suspect that there was some kind of corruption in between from the Guatemalan government, you know, wanting to have a share of the total purchase money. Something like that, maybe, we don't really know. And that is having us with no vaccines. So we, at this rate, we have in Laboratorio de Datos, we have estimated that it will take around 27 years to get our 16 million people vaccinated. So that is the gravity, the difficulty that we are facing so far.
Thank you so much. I think we've gone through all of the questions. I'll just do one more invitation to the audience. If there are any questions for any of the speakers you would like to ask, please enter them into the chat now. And okay, I think this actually brings us to the end of our forum and the end of this panel. I want to extend the deepest thanks from the City University of New York to Dr. Slowing, Dr. Redding, Erinn Bacchus, and Dr. Slack. We will have another forum in the fall. We look forward to having more conversation. This was incredibly helpful. It was a very quite a remarkable event, and we just really appreciate your taking the time to speak to the CUNY community and the broader community. And I'll give the floor to Lucia and Allison so they can also say their thanks.
Yes, and I particularly want to thank you all because we have a very large student population who's actually part of the public who's presently, who has learned, I think, an awful lot from everything you had to say, from very different perspectives. And the incredible thing is that in the end, we come up with kind of a unifying vision of, you know, what we need to do in the future. And I think it is an eye-opener for not only our students, but all of us. So we really, really appreciate this. I know for myself, I've learned an incredible amount of things and that will inform my own teaching in the times to come. So thank you all.
Yeah, and thank you. And similar to what Lucia just said, I think all of these different perspectives, there are so many aspects to, you know, to COVID that don't get discussed, and there can be, you know, an attitude in America, and I know nobody in this forum feels that way, but like, okay, the vaccine's here, everything's back to normal, and it's very much not back to normal globally, and there's just so much that needs to be done. At some point, I was going to ask what people thought about optimism, but I think there's just, yeah, this is where it's at, and you know, so much more work needs to be done. So thank you just for the diverse perspectives from everybody. It's like Lucia also said, you know, I've learned a lot just from hearing this, and I've thought about more discussion points, you know, to have with my students. So thank you all very much for that.
Yes, thank you. And the students who were not, and their mentors who were not able to make it today will be seeing the recorded version of this event. So once again, thank you to the speakers, thank you to the audience, and we wish you the best of your summer. Thank you.
Hey, thank you so much for having us. It's great. Really
wonderful. Appreciate it very much. I'd like to put a plug in for your book. Deported to Death. I just ordered it from my own class that I'm teaching in the fall. So yes, good. And if any of the other speakers have a book they would like to put in the chat or mention, please feel free. Can the team just? I'm sorry?
No book yet.
Okay. But we'll be looking forward to it when it does. Can the team just stay on for a couple of minutes after everyone else logs off? Lucia and Allison and Remy. Okay, thank you everyone so much.
Thank you. Take care, everyone.